Good morning. It's such a joy to spend the next 20 minutes or so with you at the Managing Deterioration Conference in Birmingham this morning, albeit virtually. And I'm looking forward to presenting on the subject of system solution, building the bacterial infection and sepsis insights dashboard. And I have a bit of nostalgia about presenting the dashboard this morning because the very last presentation of the dashboard before the pandemic hit back in March 2020 was at this same conference in Birmingham. And my name is Kenny Ajayi. I'm the Program Director for Patient Safety at Imperial College Health Partners. We're an academic health science network and we cover the Northwest London geography. This work has been sponsored, the work of the dashboard has been kindly sponsored by the National Patient Safety Collaborative under the umbrella of the National Patient Safety Improvement Program. And for the avid tweeters and social media enthusiasts in the room, if you'd like to tweet along or make contact in the course of the presentation or later on, either today or in the course of coming weeks, months, and days. Those are my social media contacts or handles where you can contact me on Twitter. There's also the Imperial College Health Partners handle, the National Patient Safety Improvement Program handle. The hashtag for the dashboard is suspicion of sepsis, hashtag suspicion of sepsis. And there's also the hashtag for the National Patient Safety Improvement Program. Now, I want to make 4 main points this morning. The first is to say that the consistent measurement of sepsis outcomes is a system problem which cuts across care settings and disciplines. The second point really is that we developed the Bacterial Infection and Sepsis Insights dashboard to provide a system solution to a wicked system measurement problem. And my third point really is that recent changes in the Bacterial Infection and Sepsis recent changes in the Bacterial Infection and Sepsis dashboard will increase the effectiveness of that tool to quality improvers on the front line and across the system. And finally, at the end of my presentation, I'll be inviting you as colleagues in the room to join us in piloting and landing the new version of the dashboard, which will be launched early in 2020. And the actual piloting process will be around about the end of this calendar year, so November, December time. We're looking to achieve that. So, what is sepsis? Sepsis is a severe life-threatening condition. It arises when the body starts to attack its own tissues and organs in response to an infection. So we know for a fact that nobody has ever yet had sepsis without first having an infection. And that interaction between infection and sepsis is very important. It's very important for the tool that we've developed. And it's also very important for the way that we propose that the outcomes, the scale, and the frequency of sepsis should be measured in future. The consistent measurement of sepsis outcomes was a wicked system problem. And it was a problem for 3 reasons. First, the definition of sepsis itself has changed over time. Secondly, there's inconsistent practices in coding between clinicians and coders, within coders and within clinicians. And thirdly, there is still no gold standard test for sepsis. And when you put all these 3 situations or 3 factors together, what you get is an unreliable way of measurement of sepsis outcomes over time across organizations, across regions, and nationally in the past. And so it was difficult for quality improvers to really make sense of the impact of their quality improvement initiatives, especially at trust, regional, and national levels. So there was no real means of demonstrating improvement in interventions done in sepsis until, of course, until the introduction of the bacterial infection and sepsis insights dashboard. And what we used to measure before the bacterial infection and sepsis insight dashboard came on the scene really was that we simply, based on the previous measurement methods, we simply were measuring the fluctuation in national events. And some of those events are featured on that slide. For the sake of time, I won't unpack them, but those are, you can see from that slide that there's a lot of fluctuation which was based on the previous method, and it just measured fluctuation in national events. Now, when we introduced the suspicion of sepsis insights dashboard, which we now call the bacterial infection and sepsis insights dashboard, what it did for us really is to provide a consistent and reliable measurement of sepsis outcomes across regional and national levels. And as you can see from this, graph or from this chart, here you see the previous way of measuring sepsis outcomes based on the so-called A40 and A41 sepsis codes. And here you see what you get. And here the broken red line is the total number of patients who report into hospital or admitted into hospital as emergency admissions. And what you see here, the solid red line, is the total number of patients who are admitted into hospital under the so-called bacterial infection and sepsis codes. And what you'll notice is that the bacterial infections and sepsis cohort completely mirrors the total number of patients coming into hospital for emergency admissions, as opposed to the previous way where we used to measure sepsis, which was very inconsistent and prone to fluctuations. Now, what the suspicion of sepsis insights dashboard, also called the bacterial infection and sepsis insights dashboard, does really is that it provides retrospective data, and that data is free at the point of access. It can be accessed at www.sos-insights.co.uk. It's accessible to the public. It's completely anonymized. There are no data inoperability issues with trust systems, and certainly there are no patient consent issues because the data is completely anonymized. Now, in terms of the actual usage of the dashboard, what we've found is that the dashboard provides a solution to a system problem in a way that no other tool up to date has demonstrated. So, for example, our colleagues at the West of England Patient Safety Collaborative used the bacterial infection and sepsis dashboard to demonstrate the impact of their system-wide introduction of the National Early Warning Score. Up until over a period of years, our colleagues at the West of England introduced the National Early Warning Score, but they simply could not find a way of demonstrating the impact of that intervention. They knew it was the right thing to do clinically, but they could not demonstrate it. Up comes the suspicion of sepsis insights or bacterial infection and sepsis dashboard. And from that data, they could easily demonstrate that actually by introducing NEWS2 across their system, the National Early Warning Score, across their systems, they found out that actually they provided or they reported much better mortality rates than any other region in the country. And so that demonstrated the system impact and the system utility of the dashboard. And I wanted you to hear it directly from the mouth of our colleagues in Wessex, from the mouth of our colleagues in West of England. And here is what they said. Two of our colleagues in particular, and Purely Blank, who is a consultant colorectal surgeon, and Alison Taveray, who is a general practitioner in West of England. What they said in their own words although for a long time we thought we were doing a good job clinically, and this was in reference to the introduction of the National Early Warning Score. We had no evidence to demonstrate it. The dashboard provides unique value in that no other tool we have come across has been able to demonstrate our outcomes in the way the suspicion of sepsis dashboard or the bacterial infection and sepsis dashboard does. Similarly, our colleagues in Wessex, the Wessex Patient Safety Collaborative, also used the bacterial infection insights dashboard or the BIS dashboard to really grapple with and understand at a very granular level what the so-called winter pressure really means in Wessex. And here is a quote from one of our colleagues in Wessex. Across Wessex, filtering by infection categories is helping teams to better understand the nature of winter pressures, showing that for Wessex, seasonal SOS, suspicion of sepsis patterns, are primarily an issue for respiratory SOS cases with a very pronounced impact each year in a single specific month, that is January. And so what the BIS dashboard helped our colleagues in Wessex to do was to understand that winter pressure was not about a random collection of conditions, but specifically it was about respiratory conditions, and it was not just across all the winter months, but specifically in January. And that kind of insight is a goldmine for improvers on the front line. Similarly, colleagues at the Northeast and North Cumbria Patient Safety Collaborative also used the dashboard to better understand their own population, the trends in their population, to the point where they felt it necessary to produce a training piece on YouTube, which is then circulated across the entire region, also helping improvers to hone their skills and to track their outcomes and improve sepsis outcomes for patients across Northeast and North Cumbria. What we've been able to do is to take the first version of the Suspicion of Sepsis Insights dashboard and to socialize it with colleagues across different care settings, across many different professional organizations, and to get some input, which is then informing the design of the bacterial infection and sepsis dashboard, which you can term as the second generation of the piece of work, really. And so we're thankful to patients who have had an input in the development of this piece of work. We're thankful to colleagues from the UK Sepsis Practitioners Forum, thankful to the Society for Acute Medicine, the Shelford Group, the Royal College of Pathologists, the Institute of Healthcare Records and Information Management, Intensive Care Society, CQC, NHS England and Improvement, and NHS Digital, and colleagues from across the care spectrum who have attended workshops, have attended webinars, and have attended a number of different conferences where we have presented, and they have given us very helpful feedback, which has informed the development of the new dashboard. Now, from those series of events that I mentioned, I produced a list of the things that colleagues have said that we should change in the new dashboard, or functions that we should introduce to make the dashboard even better. And I will feature a few of them in the next slide so that you can focus specifically on the changes that you'll see in the new dashboard. Now, here is a quote from a patient who was very impacted by the Suspicion of Sepsis Insights dashboard and kindly took time to send us a tweet and to appreciate the work that's been done, and obviously we've taken permission to be able to use this quote. Now, I did mention that I would feature some changes that you would see in the new dashboard. One of the things you'd be able to do, which you couldn't do in the previous dashboard, is to specifically decide at what level you wanted to slice the data. So you could look at the data at the level of primary diagnosis. You could look at it at the level of multiple diagnostic. Multiple diagnostic positions is the word I'm looking to get out. And you can also look at it at ICS level. You could look at it at trust level, and you can look at it at CCG level. What you can also do is, unlike before, you can now actually pick out individual trusts and compare them, not for the purpose of performance, but for the purpose of improvement. So you can actually now compare trusts, multiple trusts, and pick them out and compare them. And this was something you couldn't do in the previous dashboard. In the new dashboard, you can, of course, also look at the data based on age categories. So you can slice it up by age, and this is an input that we've had requested from colleagues on the dashboard. So these are new features that you will see in the new bacterial infection dashboard, which was not previously in the suspicion of sepsis insights dashboard. And of course, the tracking of variation through SPC charts is a feature that was in the older version and that you'll continue to see in the new version. So this leads me to starting to conclude the presentation. What are the next steps? We're currently working on the final iteration of the bacterial infection and sepsis dashboard in its new version, and we're hoping to complete that piece of work by the end of October. At the end of October, early November, we'll be reaching out to you and colleagues across the healthcare sector and across care settings to invite you to pilot the dashboard at trust level, at regional level, CCG, ICSs. ICSs, I think, would be the right term to use, actually. But ICSs to come and pilot the dashboard and give us a bit of user testing, give us some feedback so that we can then take that information and use it for the final iteration. We're looking ultimately to launch the new dashboard early in the new calendar year. So we're looking to do a launch in January, February 2022. And we are hoping that you can be a part of that process. Thank you very much for your time. Thank you for listening. And I hope that you enjoy the rest of the conference. And again, for those who might want to get in touch, perhaps to pilot the dashboard or to ask questions even, or just to interact with the dashboard, these are my contact details, and you're welcome to make contact. Enjoy the rest of your conference, and it's been good spending the time with you.